Hi, everyone, and welcome to the Parkinson's Foundation program, Deep Brain Stimulation. We are so glad that you're here with us today. I'm Sarah Osborne. I'm Associate Director of Community Programs with the Parkinson's Foundation, and I am based in Los Angeles County up in Santa Clarita. The chat is open, so we'd love for you to write in that chat, either to everyone or just to the panelists. Tell us where you're tuning in from. Oxnard, Simi Valley, Santa Barbara, Ventura, and we welcome you to keep that going and to keep that chat open and talking. So we do have a few polling questions to learn a little more about you before we get started. So you're going to see the first polling question appear on your screen. So we'd like to know, how familiar are you with DBS as a treatment? And you'll just select whichever one is most applicable to you. Yeah, so how familiar are you with DBS as a treatment? Okay, and can we share those results? That's great. So we have some beginners, we have some people who know a few things already, and then we have some experts. So that's wonderful. Thank you for participating. We have another poll to share. And that question is, what are your biggest questions or concerns about DBS? So that is multiple choice. You can choose whichever ones are applicable to you. What are your biggest questions or concerns about DBS? Yep, a lot of people choosing side effects. Yeah, it's brain surgery. It can be intimidating, right? All right. Yep. So the number one answer was side effects, followed by it's unclear to me who's a good candidate. It's brain surgery, and they'd like more information. So that's great. We're so glad you're here with us today to learn more. Okay, so a little bit about the foundation. Well, first, let's thank our sponsors. Of course, we want to start there. Boston Scientific and Medtronic. We thank you so much for your support. The mission of the Parkinson's Foundation is to make lives better for people living with Parkinson's today until there is a tomorrow without the disease. And we fulfill our mission through what we call our three pillars, which are better care, research and education, and advocacy. So some of you here today might already be familiar with our educational resources. So we have our series of books, we have webinars, of course, we have podcasts on our hospitalization kit, which is called Aware and Care. We also have a toll-free helpline at 1-800-4PD-INFO. And these resources can be found on our website and in digital formats on parkinson.org, or you can order print versions by calling or emailing our helpline. We also have a full lineup of more programs at parkinson.org/pdhealth. So the Foundation's newest research project is called PD Generation, and this is a free, no-cost at-home genetics test for people with a confirmed Parkinson's diagnosis. And we'll share that information in the chat. The website is parkinson.org/pdgeneration. So a show of hands, you write it in chat. How many have participated in a moving day walk? Anyone in the chat, anyone here today at a moving day walk? We do have a new event actually, which is another community event like Moving Day. It's called Parkinson's Revolution. That one is in Santa Monica this year, and it is a stationary bike event. It's also available as a virtual event, so you can do this online. We have a staff person in here today, Bernice Dedig. If you want to chat to any of the panelists to ask questions about that event, we encourage you to do so. And we hope you'll stay connected to us on our website, social media channels, and by phone, email, through our helpline. So today we're going to learn about deep brain stimulation for Parkinson's. And many of us on here will know something already about Parkinson's disease and the topic of DBS, but some of us may be new. So this session will not include an overview of Parkinson's, but we are going to copy and paste one into the chat so that if you want to watch it later, you can find out more. And if you have others questions about Parkinson's in general, please reach out to our helpline with any of those questions or concerns. Okay. And now I'm happy to introduce our guest speaker today. Dr. Bradley Hiner of Dignity Health in Oxnard attended medical school at Ohio State University and completed his neurology residency at Stanford University. He's a board certified neurologist specializing in the care of patients with movement disorders. Dr. Hiner's research interests include genetics in Parkinson's and deep brain stimulation, and you'll find his office details in the chat. Welcome, Dr. Hiner.
Well, thank you so much, Sarah. It's a pleasure to be here. And I'm really excited to be able to present this topic because it's one that I think it's a breakthrough as far as I'm concerned in the treatment of Parkinson's disease. I've got a little presentation here with some slides we'll go through, and then we'll take time to talk with some patients who've had this done. A lot of times patients are more influential than the doctors are as far as being able to answer questions about, what was it like, do you think that it provided a lot of help, or what was your result, and just your experiences. So we're excited to have a couple of folks here that we can chat with about their experiences. But first, I'm going to go through a little informational slideshow here. And, deep brain stimulation, is it for you? And that's kind of a big question. DBS is a relatively new technology, but bear in mind that it certainly is far from experimental. It was approved by the FDA for use in Parkinson's disease about 20 years ago. And actually, it had been in use probably since the early 90s, mid 90s, in Europe, certainly. They kind of led the way, but then several centers here in the United States picked it up. And I know that I've been involved with DBS since 1998. And I think I've probably done or been involved with upwards of 1,000 cases. So this is not a procedure that's an experiment. We're not, doing this without knowing full well what the consequences, both good and bad, are. And that's what we're going to talk about today. I'm at St. John's Regional Medical Center in Oxnard and have an office down here in Camarillo, where I am today, actually. This is me, and I was the director.
Pardon me, Dr. Hiner. Could you try resharing your screen because we're not seeing slides?
Oh my goodness. That's not good. Let's see here. Okay, share screen, okay.
Nothing yet. There we go.
Okay, super. Now. Good?
Perfect. Thank you.
Okay. So that's just my introduction stuff. That's me. I was the director of the Deep Brain Stimulation Program at the Medical College of Wisconsin for many years. And like I say, this is not a new technology. It's one that's been tried and proven. Going back to the beginning, Dr. James Parkinson published this little book in 1817 describing what we know as Parkinson's disease. And we all know that it has to do with the loss of the dopamine producing brain cells. On the top, you can see those black lines there. Those are the areas called the substantia nigra, and the substantia nigra is where dopamine is produced. On the bottom slides, you can see that those black cells have dried up or largely gone away, thanks to that thing on the right there you see, which is the round pink object there is the Lewy body. And what we know happens is you lose your dopamine. And if we look at a dopamine scan, on the left is a normal dopamine scan. On the right, you can see that the area that lights up is quite a bit smaller, and that indicates a loss of dopamine in the brain, which is the cause of the symptoms, the motor symptoms of Parkinson's disease. We have lots of good medications that we can use, and certainly many, if not most patients do enjoy improvement in their symptoms, whether it's tremor, stiffness, slowness of movement, trouble with balance and walking. We've got lots of things that we can do, but unfortunately, over a period of time, what we call the therapeutic window narrows, such that what works for the first year or the first couple of years becomes less effective. It seems like you have to increase the doses of, you're always dealing with, tinkering with the doses of medications, adding medications. It just gets to be a lot more complicated. And estimates are that after 5 years of Parkinson's disease treatment, most patients are starting to struggle with the quality of life issues that face Parkinson's folks. And in the past, all we could do is push more pills, basically. And we would add pill upon pill upon pill until, we've got, multiple different medications being tried. And what we're able to offer now is that rather than continue to push pills, we can do this, which is deep brain stimulation. Now, I'd like to show you this actually. Now, Medtronic is just one company. There are 3 companies. Boston Scientific is another company that makes these devices. And I want to show you actually, I don't know if you can see this. Kind of hard to see, right? Well, what I'm holding up is, this is the actual DBS or deep brain stimulation, we call it the lead. And the lead is a very thin wire. It's about the thickness of a strand of spaghetti. And this is what we insert into the brain to stimulate the part of the brain which is affected by Parkinson's disease. In this case, we stimulate the subthalamic nucleus. And the slide that I have up right now, I've got sort of a slice through the middle of your brain. And these areas are, of course, not actually green, but if you look down at the lower half of that, there's an area called the subthalamic nucleus. And when the subthalamic nucleus is deprived of dopamine, i.e. in Parkinson's, that's the whole thing, is a loss of dopamine activity. Well, when the subthalamic nucleus is deprived of its dopamine supply, it goes crazy. It gets very wildly hyperactive, actually, and very erratic. And by inserting this wire into the subthalamic nucleus and turning on a little bit of electricity, which you cannot feel, by the way, but the little bit of electricity stimulating that subthalamic nucleus results in almost immediate improvement in Parkinson's symptoms. And we're going to get into what gets better and what doesn't in just a little bit. This is this is an old kind of cartoon mock-up. We don't use 2 batteries anymore. In fact, this is an example of a more modern version. This is a rechargeable battery. It's smaller than you can see it. It's pretty small. It fits right underneath the skin of your, underneath your collarbone. And everything is under your skin. You can't see it. Nothing is external, but it's connected under your skin, under your scalp, to this stimulating electrode or lead, which is inserted into the subthalamic nucleus. And when we activate the battery, we can then control it. We can program in different parameters, how much current, lots of different things that we can do to tailor the stimulation to the patient's needs. And everybody's different. That's the thing about Parkinson's, is it's not a cookie cutter thing where everybody is on the same meds or everybody's on the same stimulator settings. We can fine tune it so it fits that particular person best. This is a gentleman that I took care of, and he came down with Parkinson's in his mid to late 40s. In these videos, he's about 61, I think, 61 or 62. And we have a before and after DBS video here. At the time we did deep brain stimulation, he was taking on the order of 20 to 22 pills of one sort or another every day. And he was sent to us for deep brain stimulation. And here he is on the left part. Oops, didn't want to do that. On the left side there, this is him off of medications. And we always do an assessment of patients off meds and on meds. We call that off-on testing. And we like to see an improvement of at least 33% in their rating scale. We use a rating scale called the Unified Parkinson's Disease Rating Scale. I use it every day in my practice, and I can give a patient a score on that particular day as to how they're doing. And the higher the number, the worse. And in this case, this gentleman's score was in the moderate to moderately severe category. Not only does he have the tremor, but he also has a lot of trouble just with basic ambulation, getting around, loss of balance, et cetera, et cetera. And he's just really struggling. This is him about a month after DBS, also on no medications. So this is what, yeah, he's on no meds at all. He's on stimulation. This is about, like I say, about a month or two after he had deep brain stimulation surgery done. I think it's important to point out that while tremor is the most visible aspect, I mean, it's easy to show a person before and after DBS who has tremor, but you don't have to have tremor to gain improvement. You know, the four major features of Parkinson's are tremor, rigidity, cogwheel rigidity in particular. The third thing is bradykinesia or slowness of movement. And the fourth is trouble with walking and balance. So while we oftentimes show folks who've had DBS that had improvement in their tremor, you don't have to have tremor to see improvement in Parkinson's. Studies have been done looking at deep brain stimulation from a scientific standpoint. And that's why I think it's important to show this kind of data, that this has been proven when you compare folks who had deep brain stimulation versus people who are on just medical therapy, i.e. just pills, and compare these two groups. This is a study that was done several years ago of almost 300 patients equally divided into those who had the surgery and those who didn't. And the folks who had the surgery, quite simply, this is the conclusion. In this randomized controlled trial, deep brain stimulation was more effective than best medical therapy in alleviating disability in patients with moderate to severe Parkinson's. So it's been proven, no doubt about it. And in fact, subsequent studies have shown that perhaps doing it at an earlier stage, not saving it for later, but actually getting in there sooner than later is a good thing. This was a study done in Europe that looked at that very thing, and they concluded that subthalamic nuclear stimulation should be considered a therapeutic option early in the course of Parkinson's disease. So who is a good candidate for deep brain stimulation? I always tell folks that there are three reasons why DBS doesn't work. The first reason it doesn't work is if the patient didn't have Parkinson's, but had one of the Parkinson mimics. And that's really my job to sort out, do you have Parkinson's disease, capital P Parkinson's, or do you have Parkinsonism, which is a lowercase p, Parkinsonism. And there is a whole variety of things that can mimic Parkinson's disease. And you better make sure that whoever is your whoever's taking care of your Parkinson's disease knows what they're doing. And because we have to sort out these other mimics that can masquerade as Parkinson's disease. And these folks, you would not send for deep brain stimulation surgery. Normal pressure hydrocephalus, multiple small strokes. There are things called Parkinson plus syndromes, multiple systems atrophy. Some of those conditions, we would not do surgery, wouldn't expect DBS to help. Basically, a candidate for deep brain stimulation is an individual who finds that they're simply taking more and more pills with less and less benefit and more side effects. It's kind of a simple, straightforward approach. If you're taking medications and you're happy with how you're doing and you don't mind taking more pills, and you're not having any side effects, and certainly Parkinson medications, every single one of them has a whole list of side effects that may occur: confusion, hallucination, disorientation. Those are some of them. Dyskinesias. When you see Michael J. Fox on TV, oftentimes he has dyskinesias. He's dyskinetic, so he's in constant motion. He's got all of these weaving and bobbing movements, which are a side effect of medication. It's not Parkinson's that's causing those involuntary movements. It's actually the medication. So if you're taking more pills, you'd like to get off the pill merry-go-round, then the way to do it is with deep brain stimulation. But bear in mind that it's not a last resort treatment. So we use a rating scale for Parkinson's disease, and I use it every day when I see patients. It's called the Hone and Yar. Melvin Yar and Margaret Hone were two physicians that came up with this rating scale. It's from 0 to 5. That's actually, they came up with this back in this, I think, late 1960s, early 1970s. And so 0 is basically normal, 5 is awful. 5 is what we would think of as end stage, worst case scenario. If a patient comes to me and I find that they have progressed to a stage 5, I do not recommend surgery. We want to catch patients ideally between stages 2 and 4. And an ideal patient would be a person of stage 3, but starting to slide downhill and starting to lose their quality of life. The stages are something that I can assign. You folks don't necessarily have to know how those stages are assigned, but just trust me that we want to catch folks that are in the moderate stage of Parkinson's before they progress to a point where it won't, because there is a window of opportunity. We want to emphasize that. And if a person develops dementia, and we always do neuropsychological testing before surgery, if a person has developed cognitive decline and dementia, we would not do the surgery. What deep brain stimulation does is it gives you whatever your best on time is. In Parkinson's, we talk about on and off stages. So when you're on, that's when your meds are working and your dopamine receptors are all firing and everything's good. And you have a period of time where you can do whatever you need to do or want to do. So if you think of whatever your best on time is, what deep brain stimulation does is extends the duration of that on time and does so with fewer medications. In fact, we expect to be able to cut medications by half in most patients. Dyskinesias and tremors actually may be a marker for a good response to DBS, but all of the features of Parkinson's may improve. So in order of improvement, tremor and rigidity, those get better, literally in the operating room. When we implant the lead, and I can test it in the operating room with a handheld battery that I have, and I'm actually in the operating room, I'm interacting with the patient. And so when we put the lead in place and then we the surgeon throws over the cable and I attach it to the battery and I test it, literally within seconds to, I mean, just almost that quick, tremor and rigidity improve. The rigidity just melts away. It's really quite remarkable. But over the long term, dyskinesias, bradykinesia, gait imbalance, all of these things may improve significantly with subsequent programming. And the programming may take a couple of months to really fully take hold. So we tell folks, hang in there. What we have for improvement at 1 month, we may be able to get even more improvement over the course of a couple of months. But usually by around 3 to 6 months, we're pretty tuned in. We pretty much got everything adjusted appropriately. Things that don't get better, if a person comes in and they have a lot of falling, and if in fact, if falling was one of their earliest Parkinson problems, that may not be a person that I would strongly recommend deep brain stimulation for. On the other hand, if their gait and balance problems are in the context of other Parkinson symptoms, and it's not just isolated falling, we may see considerable improvement. So it's really an individualized thing. Non-motor symptoms do not get better with deep brain stimulation, and non-motor symptoms are things like memory loss, cognitive decline, fatigue, low blood pressure, restless legs, et cetera, et cetera. Not, the symptoms that get better with DBS are the motor symptoms. I want to emphasize that. And that's me. If you want to contact me, you don't need to be referred. I would be happy to see you. And I think now is a good time to kind of switch gears a little bit and talk with some patients. So let me click out of that. Okay. So we are very pleased to have 2 patients. One is here with me, and the other is with us virtually. Steve Hager is in Florida. Steve had his deep brain stimulation done in Florida, and he can talk about or share with us his experiences and what he thinks about it. And I'm here in my office in Camarillo, California, and we are going to be talking a bit with Joanne about her experience with deep brain stimulation as well. Let me just start with you, Steve. Can you hear me okay?
I'm good, yeah.
Yeah. So Steve, tell us a little bit about yourself, your age and when you were diagnosed and when your surgery was done.
I'm 65. I am a professional musician. I have been. I'm not currently. I retired because of Parkinson's. I have a long history of playing keyboard, but it was stopped by Parkinson's about 2014. I was diagnosed. My symptoms were very minor then, tremor in my right hand, just a little bit of tremor. And that proceeded 3 years later to be shaking my whole right side, which is, as you can see, gone. And it was a gradual process of getting worse with the Parkinson's and Parkinsonian symptoms. I took levodopa, started in 2015, more levodopa. And I tried a couple other meds, they didn't work. And then that led me to the point where thinking, well, I'm not going to keep taking more meds because I know that it's going to cause more dyskinesia and more problems. And what do I do? What's the solution? So that's what led me to wanting to take matters in my own hands and find somebody to do the surgery. So I was living in California. It didn't work out to have it in California. So I came to
Hey, Steve, hold, Steve, hold on just a sec. Are we having problems, Kayla, with folks not getting the video?
Nope, I can see the video quite well.
Okay, good. I just saw that somebody popped it up that said,
Nope, just bouncing back between Bradley Hiner and Steven here.
okay, super. All right, back to Steve. Sorry, Steve.
Okay, so that's that's my beginning story. I went to Kelly Floyd at University of Florida. He was fabulous. They did a thorough evaluation, including psychological, to make sure I was not having any problems before they did that. And they approved me, and it was remarkable what it changed. Because when I came into the surgery, I was as well as being a piano player and playing piano 8 or 10 hours a day, literally for 35 years, 40 years. I also worked on a computer as an electronic musician in the studio, typing and entering things on my keyboards and different instruments in the studio. I wasn't able to do that anymore. My right hand, which is I'm right dominant, was not working at all. So I changed that immediately, but also I couldn't hold a glass of water. I was shaking so much, I couldn't hold a glass of water or shave, or it was terrible. I brushed my teeth with my left hand. So I changed all that immediately. I knew it worked right away in the surgery because they tested it before they closed the surgery up. But then after they did the programming, it was fabulous. It takes a while with the programming. They must have tried like 15 to 20 different settings. So I got to a point where I was like, that's the one. That's perfect. Now I'm sure they could still program more and go on and on and on with programming, but I have to get back to being Steve Hager and not letting it consume me. So now I go everything also check out.
Steve, if you had to do it over again, would you?
Of course. It's improved my life tremendously. And especially, I'm 65, I'm a young 65. I play tennis. I thought when I was a child, because I lost my left eye to a stupid accident, I didn't have hand-eye coordination. When I was 50, I started playing tennis, so I'm pretty good. I'm very fast. What's not fast is my feet, but visually, the hand-eye, I'm super fast. And that comes from playing piano.
Sure.
So I'm able to do that. I play tennis 4 or 5 times a week now.
Yeah.
It's fabulous. It's
Yeah. Well, you know, what I oftentimes tell patients, and correct me if I'm wrong, but, you know, if if Parkinson's is kind of a steady decline in your dopamine production, and as a result of steady, you know, progression in Parkinson's symptoms, deep brain stimulation kind of pushes you back up that ramp 5 or 10 years. So it doesn't change the fact that you're still on a slide. You're still on the, I mean, because we don't know what causes Parkinson's. But it just gives you the advantage of, it's kind of it's like hitting the reset button. Is that a fair statement?
I think so.
Okay, so I've got Joanne here with me today, and I'm going to show you guys a little bit about how we would do programming. And for this, actually, I'm going to want to get I'm in my office here, so we're kind of just winging it. Well, I'll just pull this over here. This is how we program. This is a tablet, laptop type of a deal here. And on the tablet, it gives me a schematic representation of the tip of the lead. And at the tip, we have there are 4 silver platinum bands, and these are called contacts. So we have 4 contacts. This particular type of lead, in addition to these 4 contacts, the 2 in the middle are segmented. so we can individually pick segments to have as active. And in that way, we can a lot of times program away from any side effects. So it gives us a lot of flexibility. And in the programming, the things that I can do, we can see over here, there are different things I can pick and choose from. As Steve alluded to, there are so many different iterations or combinations of, we start with kind of a standard starting point, but we can really fine tune your stimulation to your particular needs, because everybody's Parkinson's is a little different, sometimes a lot different. And so this is how we program. Joanne had her DBS done. When was your?
December 7th and December 12th,
And
19th.
I'll ask the same question of you. If you had to do it over again, would you? And what has it done for you?
I think I definitely would do it again.
Speak up.
Thanks, I will. Sorry. It has helped me tremendously, and I will definitely do it again. It has helped me with my stiffness and rigidity for sure. It has helped me with some tremors. It has helped me, it doesn't help everything though, and that's okay. I kind of maneuver my way around those things. What else? I'm 60 years old, and I was diagnosed about 15 years ago, I think, something like that. And I was seeing the movement disorder specialist, and he kept saying, Joanne, it's time you consider this. Joanna said to consider this. And I was too frightened, so I understand the fear that a lot of people have. And about 3 years later, he said, Joanne, you really need to consider this. And I said, yeah, I do. I do need to consider it, because my symptoms were really quite bad. So I considered, I thought about it, we talked about it with my husband, family, friends, weighed pros, cons, brain surgery, side effects, all the things that everyone's concerned about. And I decided to do it. And I'm really glad I did it. So well worth it. Doesn't treat everything, but if you're looking to have less stiffness, less rigidity, then that's definitely the way to go.
Yeah, and I mentioned earlier that it's so gratifying. I have the luxury, I guess, of being involved from the moment the patient walks in the door. I get to talk with them and examine them before surgery. I'm in the operating room during surgery, and then I get to do the programming afterwards. So it's such a joy to see the improvement that can occur. But this is a question for both Steve and you, Joanne. What kinds of things do you hear from other patients as to why they wouldn't do it? What are they afraid of, or what are their concerns?
I think that most people I speak with and have them do, like a moving day, I talk to people,
Okay.
and their concerns mostly are it's brain surgery. And does it have to be done awake or asleep is another choice that they have to make. And that's a hard choice to make. I chose
Sure.
being awake.
Yeah, and we like, we like to have, in fact, in practically all cases, we do the surgery with the patient awake, but bear in mind that they're asleep during the initial part, where we basically drill a hole in your head. That sounds horrible, but that's what it is. It's called a burr hole. It's about
The loudest sound you'll ever hear. Really loud. The drill.
yeah. Well,
It's not scary, because I was so happy to have that surgical team thinking about me,
yeah,
treating me, doing what they're going to do, and they're great.
yeah.
I'm sure your team is great too.
Yeah, so the drilling part is It takes a couple of minutes, literally. And once that's done, everything that we do is done with a very fine probe. So we're not in there mucking around, and it's not, it's really, it's almost at more of the level of a biopsy type of procedure, because it's done with this very fine probe. And again, bear in mind, this is what we use. I'm not sure if this is going to show up, but this is an actual DBS lead, and it's about the thickness of a strand of spaghetti. So when we pass this down into the part of the brain that we want to stimulate, we stimulate the subthalamic nucleus. This doesn't do any damage on the way. People are worried, well, is it damaging my other brain parts when you put that in there? And it doesn't. It's such a fine and small diameter probe that it really doesn't do any brain damage. And a lot of folks are worried about, and I understand deep brain stimulation sounds, oh boy, that sounds horrible. But I think that most people, once they've had it done, they go, that wasn't nearly as bad as I thought it would be.
The brain surgery part, there's two surgeries. One to put the lead in, one to put in the pulse area.
Right.
The second part was with the pulse area, it was actually a little bit more painful because there was soreness from this from tearing into my skin.
Yeah, and that's exactly right. Of course, the battery, this little dude here, putting this battery in is no different than you getting a battery put in for your heart pacemaker. It's the same procedure. So, and that's obviously a procedure that's done all the time, millions of folks. So it is, these are, let's talk about potential side effects or complications. The complication rate for deep brain stimulation surgery is quite low, and it is really dependent upon the experience of the folks that do the surgery. In our hands, we've had the most common side effect, if there is one, or most common complication, is an infection. And the most common infection is a pocket infection where the battery is. And the rate for that is no different than people who have a heart pacemaker. So it's a couple of percentage points, folks. They'll get an infection in there. It can usually be treated just with antibiotics. Rarely, and this would be less than 0.0%, 9%, you have to remove the battery, clean everything out, and then let it heal up before you put the battery back in. But for most folks, if you do get an infection, we can cure it with simple antibiotics. The more worrisome complication would be if the infection occurred not where your battery is, but up top, where you're on your scalp, where the lead goes into the brain. And if it's a skin infection, we always call in infectious disease specialists if this occurs. I think over the course of the 20 years that I've been involved in doing this procedure, you could count on maybe one or two hands at most the number of people where the skin infection resulted in everything being removed. And that happens, but it's vanishingly rare. So that would be a complication that we're well aware of. Neurologic complications, like, is this going to damage my brain, or is this going to make me dumb, or is it going to affect my cognition? And these are concerns which come up. And I just try to reassure patients that we wouldn't do the procedure if we thought it was going to do you harm. We want to do good, and that's where we get our joy, is seeing folks get better. And it's not like iffy. The thing about DBS is it's not iffy. It's in the right patient and with the right team of doctors, it can just make a huge difference. Sort of like when a patient is first diagnosed and the first time that they get levodopa, usually when I see a patient back a month or so later, they say, gosh, I feel so much better, and blah, blah, blah. So it's that level of improvement that we can get with deep brain stimulation that's just so satisfying. So should we take some questions from any other folks? Kayla?
Hi. Yeah, we do have a few questions, Dr. Hiner.
All right.
So I will just get started then.
Sure.
So the first question is, I've heard it's recommended to wait at least 5 years from diagnosis before having DBS. Is this true?
Well, I had that one slide that supported earlier use of DBS rather than later. And one thing that we do emphasize is don't save this till the bitter end, because it won't work and we won't do it. If it, again, going back to that rating scale, the Hone and Yar or HY rating scale, we want to catch you when you're in the early to medium range. So the scale 0 to 5, we want to catch you at a 2 or a 3 if possible. Once you head towards 4 and 5, then we're less likely to do it. But again, everybody's different. I mean, we take it on a step. One thing is age that comes up sometimes. The oldest person that I personally was involved with and did DBS on was 87. Now, maybe 86, but I mean that's really old. But this guy, he was so terribly, I mean, affected that it was worth it, and he did really well for his remaining years. So, whether or not we do it within the first 5 years or after 5 years is really dependent. So, I've had patients where they just hated taking pills. And I think Steve was kind of like that, weren't you? I mean, taking pills, and I think that's a very healthy attitude to be sort of cautious about medications. So I've had a number of patients where they were not on a high level of medications. It's just they didn't want to take them at all. And I've had a few patients where after DBS, they didn't need any medication. So we would do DBS in those circumstances, but that's unusual. Usually we want to see a person who's been on a steady, adequate dose of medication, carbidopa, levodopa, still the mainstay of treatment. We want to see that person responded to therapy, but now they're not. Now they're having to take more and they're starting to struggle. So that's the person we want to catch them at that point. And that usually has them in the 2 to 3 range on our Hone and Yar scale.
Thank you. And I don't know, Kayla or Danielle, if you would mind sending a link about the scale in the chat to everyone so we can learn more.
Oh, that's a great idea.
Yeah, so the other question that we had was if DBS is permanent, once it's done, is this just something that lasts for a long time, or, are there adjustments that need to be made and so forth?
Yeah, and that's a great question. And that's one that gets also rightfully asked a lot. How long does it last? How long is it good for? Well, we think it lasts a very long time. Patients who've had it done 10, 20 years ago, if they come into the office and we turn, let's say that we turn the battery off just to see how things look without the stimulation. Almost invariably, we see that their symptoms get much worse almost immediately. I think Joanne can attest to that. When her DBS is turned off, what happens?
Within 10 seconds,
Okay.
everything starts to get worse. My tremors are worse. My feet start to dance around.
Yeah. So that's all. We think that the benefits of DBS last a long, long time. It's just since it's not curing the disease, the disease progresses. And so we do need to tweak the settings over time. And that's why we have patients come in every couple of months for maintenance, on their, we check the battery out, make sure everything's working good. We can do that really hands-on. We don't need to cut you open or do anything in your head, in your brain, because we have this wonderful technology that we can do it with hands-free, and we can tinker with settings and try to readjust it so that patient symptoms, if they're starting to get worse, we can recapture some of the improvement. But over time, Parkinson's is a progressive disorder, and it's a battle.
So another question that we had was about the medications, and somebody wants to know sort of what is the maximum amount of pills? How do you know when you're taking perhaps too much or the maximum amount of medication?
Well, ultimately how you know is side effects. All Parkinson medications have potential side effects, and you will realize that potential by increasing the doses in a manner that ultimately you hit a limit. Specifically with respect to levodopa, many folks will recognize that their prescription for has carbidopa levodopa, and there are two numbers, let's say 25/100. Well, the 25 is 25 milligrams of carbidopa, and the 100 is 100 milligrams of levodopa. Although they sound the same, carbidopa and levodopa, carbidopa really does nothing for Parkinson's. I wish they'd given it a different name. It's the levodopa portion. So if you're on 25/100 carbidopa levodopa, then you're getting 100 milligrams of levodopa. If it's 3 times a day, 100 times 3, 300. So you're getting a total per day of 300 milligrams. The daily dose can go as high as 2,000 milligrams. So 300 milligrams, that is a low dose. That's a beginner's dose. I personally find that the 25/250 tablets oftentimes are the best choice. And if you took a 25/250 3 times a day, that's 750 milligrams of levodopa. And that still is not near the limit. Again, the upper limit that I use is 2,000. I rarely go that high. Once we start progressing over 1,000 milligrams of levodopa daily, then I'm going to be looking to add on. If we want to continue in the medication realm, at that point, I would add on adjunct or helper medications. And we've got a lot of choices there. I had that one slide. There's a lot of different things that we can manipulate pharmacologically, but ultimately, at some point, more pills isn't the answer. In fact, as you go up on the pills and try adding and combining and doing all these different gyrations, as you do those things, you're looking at more side effects, and it really impacts on quality of life. I think Steve can probably speak to that as well. I think that's a person where you would like to be able to, you want to be able to offer it, at least bring it up as a point of discussion. And all too often, I find that patients aren't given that opportunity because their personal physician either doesn't know about it or doesn't believe in it or is uninformed, et cetera, et cetera. And I think it's almost malpractice if the patient is not offered the opportunity to at least talk about it. And you need to, and it needs to be with somebody who has experience. I'm not patting myself on the back. I'm just saying, you want to be with a doctor who knows what he or she is doing and talking about and has experience with deep brain stimulation, because a lot of, this isn't part of our medical school training, by the way. Maybe it's starting to get into the curriculum to some extent, but still, this is relatively a newfangled thing, even though it's been around 20 and approved for 20 years. And worldwide, tens of thousands of patients have benefited from deep brain stimulation, but a lot of docs still, they're wary or they're just uninformed. So anyway, that's my.
Yeah, thank you for that. And then we had a question submitted ahead of time that was, are there other conditions that could impact the effectiveness of DBS? So I think specifically if they had like a pacemaker, or is there any other illness or comorbidity or other device
Sure.
that could impact DBS?
Well, of course, we have to take into account the patient's overall medical health, their general health status. And certainly if a person has poorly controlled diabetes or congestive heart failure, all of these things have to be taken, before we would do the surgery, we want to look at the whole person. And we want to make sure that we're not going to put their health otherwise at risk. We don't want to, do no harm. That's our motto. But as far as things that can specifically interact, like pacemakers, and that comes up, we do DBS in patients who have pacemakers, not a problem. We do DBS in patients who've had spinal cord stimulators for treatment of chronic pain. We do DBS in
Seizure disorders.
seizure disorders, epilepsy. Good point. Joanne brings up a great point. What about a person who has epilepsy? Well, we would work with that patient's epileptologist, the doctor who is managing their epilepsy, to make sure that we're not going to be at risk for provoking an epileptic seizure. In most cases, if they're on an adequate medication regimen for their epilepsy and it's well controlled, then we don't have any qualms about doing the surgery, because we're not, I want to emphasize again, everything is done with a probe. We're not affecting large parts of your brain. We're not disturbing parts, large parts of your brain. So if a patient had epilepsy and it was well controlled on medication, we would go ahead and do the surgery. That's that would be a pretty uncommon situation. I think maybe a couple of patients that I've had over the years, and they had no problems with it at all. They just continued their meds.
Great, thank you. We do have a few questions that are maybe more practical in nature, so I'm going to ask them at the same time. One is, does Medicare cover any of the costs? And then the second one was, we had a few people just expressing like what changes have happened in getting DBS or getting programmed with DBS since COVID restrictions.
The first question is easy. Yes, Medicare covers it, and all insurances cover it. So that's not an issue at all. Thank goodness. With respect to COVID, I haven't really run into any Parkinson specific situations.
I have.
Did you have COVID?
I did. When was it? I could not be programmed for I had one programming before COVID, and I had to wait something like 9 more months before I could get reprogrammed again. And that was a difficult time.
Sure.
Plenty of physicians, plenty of businesses closed, including doctors' offices. They closed their practices.
Yeah.
And that was challenging. That's challenging. You have to find another physician, you have to get reprogrammed. It could take months on end.
Yeah, and that kind of brings up another point. What happens if something like COVID comes and you can't get programmed and you're kind of left high and dry? Well, then you're working with your doctor over the phone or by a video conference, because we would have to tide you over with adjusting your meds, basically.
So.
And until we can get you back into the office. The programming does have to be done face to face. I understand that there is some work being done on remote programming where the patient might be at home and perhaps hold some type of
I have
device, and you can do it over the phone. Yeah. So sure.
I brought with me my remote and my charger. Both.
Patients are allowed within limits to do their own adjusting without having to come into the office. So we can set up the system, which I don't know if you guys can see this little handheld deal. We can set the system up so that the patients can increase or decrease certain settings on their own without having to come in. So that is a great advancement. Oh, great. Oh. Just have to log back in, guys. Come on, computer.
You're still on screen with us, so you're good
Oh,
on
good,
our
good, good. Okay, great. Now I'm back.
end.
So anyway, yeah, I don't know if
Fun
that,
with technology.
yeah. I don't know if that answers your question, but
But it's a great little tool.
yeah.
Yeah, I think this is really important to tell people what, maybe what the challenges would be too, to be realistic. And that would be then, I think the last question is, we heard side effects and we heard about good outcomes from our two people with Parkinson's and from you, Dr. Hiner. What would a negative outcome look like, and what are the challenges that we should keep in mind as we ask our doctors about DBS?
Well, one challenge is meeting expectations. Some folks come into this, and even though we tell them, we're not curing your Parkinson's, you still have Parkinson's, we're just helping it. We're pushing you back up that dopamine ramp, but you still have Parkinson's. So sometimes unrealistic expectations, and a person, if that's the case, because they're not perfect, they're not going to be perfect. And I guess going back to the same message, which is you have Parkinson's, and this is going to help your Parkinson's, but you've still got it. And there's a lot of, and we talked about this, I think, on Sarah, on one of our Zoom conferences about the non-motor symptoms of Parkinson's, and the non-motor symptoms are not dopamine responsive. And these are things like changes in cognition, memory, thinking processes, problem solving, judgment, multitask. I mean, all these things that go into our brain that we use every day for, just daily activities. That's a non-motor part of Parkinson's. Non-motor symptoms, constipation, bladder problems, blood pressure, all these things that can occur are not going to get better. So, if a patient comes in and says, well, is this going to help my sense of, I lost my sense of smell. Well, it's not going to help that. It's not going to come back, right? Some folks have terrible sleep problems, including REM sleep disorder. Probably not going to help that, or insomnia, probably not going to help that. I don't know. Some studies, because I looked at this for my sleep talk in Parkinson's, and some studies showed that a certain percentage of patients actually did improve their sleep after DBS. I don't know, Steve, what would your comment be? Maybe he stepped away. So, Joanne, did it help your sleep problem?
No.
Yeah, so sleep is one of those non-motor stuff, non-dopamine related stuff. Not going to help.
You can always find me in my living room at 4 o'clock in the morning playing on my Kindle.
Okay, all
My
right.
sleep has improved tremendously.
It did improve, okay?
Yes, and I was on several drugs for a couple of 3 or 4 years to try to help me sleep before I took more levodopa, which didn't help me sleep either.
Right.
It's just Parkinson. I take like one melatonin if I need it. And
Yeah.
Oh, that's great. I think it's important for us to, realistically consider all of these things and be realistic in our expectations.
Right.
I just want to thank all of you so much for your time today and for sharing. It was really great information. I really appreciate your insight. Unfortunately, we're out of time. I do want to let everyone know that we are going to share Dr. Hiner's information again in the chat, and then we will also share our helpline information. So if you have remaining questions, you can get them answered. Please reach out to us. And yeah, we hope you stay in touch with us with any of those questions. So thank you. We want to thank Dr. Hiner, of course, Dignity Health of Oxnard. We want to thank Boston Scientific and Medtronic, and we want to thank all of you for attending. Again, today's session has been recorded. We'll archive it and we'll put it on the Parkinson's Foundation YouTube channel within a few weeks. We're going to send everything via email after this as well. It'll just take a couple weeks to prepare and we'll send it out. Again, if you had any questions that weren't answered, please reach out to us at 1-800-4PD-INFO or email helpline@parkinson.org. That same information can be used to order our free resources, educational books, hospital safety kit, and so forth. And with that, we will conclude the program. Thank you again for joining us and stay safe.
Great, thank you.
Thank you.